Hey everyone, welcome back to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm your host Ahmad Sabbah, and today I'm joined by Ibrahim and Alodhaibi.
Hey everyone, super excited to be here for the first ever episode of the new PodBites series, CaseBites. In this episode, we're stepping into the NICU, a tiny world where patients are literally a couple of pounds, but their medical challenges are massive.
And here's what we're going to unpack, nice and organized so you can follow along. NRDS, apnea, BPD, ROP, IVH, hypothermia, and finally NEC. So basically, lungs first, then eyes, brain and temperature, and finally the gut. So to kick us off, when we talk about prematurity overall, what's the most common thing acutely, like right when the baby is delivered?
That one is breathing issues, especially NRDS, or Neonatal Respiratory Distress Syndrome.
Okay, so what's actually going wrong in NRDS? Because I remember something about surfactant.
Yes, the root problem is surfactant deficiency. Surfactant, made by type 2 pneumocytes, keeps alveoli open. Without it, they collapse, the lungs stiffen, gas exchange goes down, and the baby develops hypoxia with both respiratory and metabolic acidosis.
Right, they look like they're working so hard. What are those classic signs again?
So you'll see tachypnea, nasal flaring, chest retractions, cyanosis, and that classic expiratory grunting. And blood gases show respiratory and metabolic acidosis, plus hypoxia.
And the x-ray? The one that we all memorize for exams?
That's the ground glass appearance with air bronchograms. Sometimes there's atelectasis and overall hazy, underinflated lungs.
Okay, give me the classic risk factors.
Prematurity, maternal diabetes, because fetal insulin will inhibit surfactant, and C-section delivery since it prevents that fluid clearing squeeze.
And prevention. This is actually something that we can intervene in, right?
Absolutely. Betamethasone from 23 weeks onward if preterm delivery is expected.
Okay, sticking with breathing for a second, let's talk apnea of prematurity. This one scares a lot of people the first time they see the monitor alarms go off. Why do these babies suddenly stop breathing?
So the main reason is actually developmental. The respiratory control center in the brainstem is immature. It just isn't fully wired yet to sustain consistent breathing, especially during sleep or after feeds.
Right, and we're not talking about just a pause, right? These apneic periods can be associated with bradycardia and oxygen desaturations, which is why everyone rushes to the bedside.
Exactly, and the good news is most preterm infants grow out of it. Babies born at 28 weeks and up usually resolve by 36 to 37 weeks post-menstrual age.
So basically, time and maturation are the cure, but we still need something to get them safely through that early period. And that's where caffeine comes in?
Yes, caffeine citrate is the first-line therapy. We give 20 milligrams per kilogram loading dose, followed by 5 to 10 milligrams per kilograms per day of maintenance. And we think about stopping treatment when the infant has been free of significant apnea and bradycardia off positive pressure for 5 to 7 days, or they reach around 33 to 34 weeks PMA, or post-menstrual age, whichever comes first.
So caffeine basically acts like a respiratory stimulant, buying time until the brain's control center matures. Now, the babies who survive NRDS often end up with another problem, BPD. What exactly is going on here?
BPD is basically the chronic lung disease of prematurity. It happens after a premature baby has needed things like mechanical ventilation or prolonged oxygen therapy, usually because of NRDS or another respiratory issue.
So it's not a disease they're born with, it's something they develop as a result of treatment?
Exactly. Think of the preemie lung like a delicate tissue paper. Mechanical ventilation, high oxygen levels, and inflammation can injure it. Over time, that injury leads to inflammation, scarring, and impaired lung growth. So instead of a normal sponge-like alveoli, the lungs become more stiff and fibrotic.
And how does this show up on imaging?
On chest x-rays, you can see a mix of findings, including atelectasis, diffuse granular densities, or sometimes hyperinflation. It's this patchy, irregular pattern that reflects scarring and arrested alveolar development.
And clinically, these babies often stay on oxygen longer, right?
Exactly. They need prolonged respiratory support, have recurrent desaturations, and are more vulnerable to infections. So BPD becomes a long-term follow-up issue even after the NICU stay.
Before we move on to the brain, let's shift our focus to the eyes, because literally every premature baby ends up with eye follow-ups. Why are we so concerned about retinopathy of prematurity, or ROP?
The retina in preterm babies is still developing. When we give high oxygen, as we often have to in the NICU, it can disrupt normal retinal vascular growth. Instead of nice organized vessels, you get abnormal neovascularization, and these vessels are fragile. They can actually pull on the retina and lead to partial or even complete retinal detachment.
So it's that frustrating balance. Oxygen is absolutely life-saving for their lungs, but it's kind of dangerous for their eyes?
Exactly. It's a constant balancing act in neonatology. Save the lungs, but don't overwhelm the retina with too much oxygen. That's why we carefully target oxygen saturation ranges instead of just giving as much oxygen as possible.
And that's why ophthalmology comes into the picture so early. When do we usually start screening?
Around 4 to 6 weeks after birth. Earlier screening doesn't help because the pathological vascular changes take time to appear.
And if the abnormal vessels look threatening, what do we do?
In severe cases, we use either laser photocoagulation to stop abnormal vessel growth, anti-VEGF injections to inhibit neovascularization, or even surgery if retinal detachment is developing.
So ROP is basically all about catching those changes early and stepping in before permanent vision loss happens.
Exactly. Prevention, surveillance, intervention. That's the whole formula.
All right, shifting gears from the lungs to the brain because preterm babies like to challenge every system at once. Let's talk about intraventricular hemorrhage, or IVH, the most common and one of the most important neurologic injuries in prematurity. So where exactly does this bleeding happen?
It comes from this little delicate area called the subependymal germinal matrix. Think of it like a nursery for developing brain cells, super active, super vascular, and unfortunately, super fragile. Bleeding from this area can spill into the ventricles. The biggest risk factors? Birth weight under 1,500 grams or gestational age under 32 weeks. Those tiny, tiny babies are at the highest risk of this.
And once we suspect IVH, staging becomes important because the grade really tells you how severe things are. Walk us through the classification.
We diagnose IVH using cranial ultrasound. It's quick, safe, and perfect for fragile newborns. The staging goes like this. Grade 1, bleeding is limited only to the germinal matrix. Grade 2, blood extends into the lateral ventricles, but the ventricles keep their normal size. Grade 3, now we have bleeding plus the ventricles becoming dilated. That's hydrocephalus. Grade 4, the most severe, blood extends into the actual brain parenchyma.
So basically, grade 1 and 2 are inside the system, grade 3 adds pressure, and grade 4 means structural brain injury.
Exactly, and because of how vulnerable preterm babies are, even small bleeds can have long-term implications.
Since we're already talking about neurologic vulnerability, this is a good time to bring up something that affects brain metabolism, and honestly, every system in the preemie. Hypothermia. Why are these tiny babies always freezing? I feel like they're cold just looking at them.
That's exactly the issue. They lose heat incredibly fast because they have an immature epidermal barrier, very little subcutaneous fat, and a large surface area to weight ratio, so they radiate heat way faster than a term baby or an adult would.
And that's a big deal because temperature isn't just comfort, it affects physiology, right?
Absolutely. Hypothermia can cause metabolic acidosis, hypoglycemia, and even impair oxygen delivery to tissues. In preterm babies, temperature control is literally a vital sign, and failing to maintain warmth can worsen respiratory and neurological outcomes.
So even something as basic as temperature becomes life-threatening pretty quickly.
Exactly. That's why management starts the second they're born. We place them in a radiant warmer or incubator, use plastic wraps for very low birth weight infants, and make sure the delivery room is warm and dry. Prevention is really the whole strategy here.
So the goal is basically don't let them get cold in the first place, because getting them warm later is much harder.
Exactly. Once they're cold, you're already behind.
Gut time. Necrotizing enterocolitis, or NEC.
NEC is actually the most common cause of acute abdomen in preterm infants, usually showing up around 2 to 4 weeks of life. A classic case, a tiny preemie on ventilation who suddenly develops a distended abdomen.
Right, and because NEC can escalate fast, we use Bell's staging to guide diagnosis and management. Walk us through the stages.
Absolutely. So stage 1, or suspected NEC, the baby looks unwell, lethargy, gastric retention, and a distended shiny abdomen, maybe even rectal bleeding. Stage 2, proven NEC, things get clearer. On the x-ray, you'll see pneumatosis intestinalis, gas inside the bowel wall, or even gas in the liver, pneumatosis hepatis. There's more tenderness and systemic signs. Stage 3, or advanced NEC, this is when the baby looks really sick, sepsis, peritonitis, and often intestinal perforation.
And the x-ray finding, pneumatosis intestinalis, that's the famous one students love to spot.
Exactly. It's the definitive radiographic sign.
So once NEC is diagnosed, what's the immediate management?
Step 1, stop all feeds. The baby becomes NPO to rest the gut. Then, gastric decompression, IV fluids plus TPN, broad-spectrum antibiotics, typically ampicillin plus gentamicin plus metronidazole. Supportive care is crucial, and severe cases may need surgery if perforation occurs.
Wow. Lungs, eyes, brain, temperature, gut. Prematurity hits everything at once.
Yep, but once you understand the developmental physiology, everything connects.
Before we close episode 1, let's test ourselves with 2 quick questions. What substance produced by type 2 pneumocytes is deficient in NRDS? And which prematurity-related condition involves bleeding in the germinal matrix and is graded by ultrasound? Think about them while we recap. So today we focus on complications of prematurity, beginning with Neonatal Respiratory Distress Syndrome, the classic surfactant deficiency that causes respiratory failure and that ground glass appearance on x-ray.
Then, we covered apnea of prematurity, which is really due to an immature respiratory center, hence why caffeine becomes our first-line therapy.
From there, we talked about bronchopulmonary dysplasia, the chronic lung disease that develops after prolonged oxygen or ventilation.
We also discussed retinopathy of prematurity, related to oxygen-driven abnormal retinal vessel growth, and the reason we screen premature infants.
Then we moved into the brain with intraventricular hemorrhage, bleeding into the fragile germinal matrix, especially in very low birth weight infants.
And along with the brain vulnerability, we talked about hypothermia, since preterm babies lose heat rapidly and need aggressive thermal supports.
And our final stop was the gut, necrotizing enterocolitis, the most common acute abdomen in preemies, presenting with abdominal distension and pneumatosis intestinalis.
So, just to remind everyone, our first question was, what substance is deficient in NRDS?
And the second question was, which condition involves germinal matrix bleeding and is graded by ultrasound?
So, the answers were surfactant for NRDS,
And intraventricular hemorrhage for germinal matrix bleeding.
That officially wraps up episode 1.
Next time, we'll leave prematurity behind and explore neonatal respiratory disorders not due to prematurity, like transient tachypnea of the newborn and meconium aspiration syndrome. See you in episode 2, where no topic is too tiny for tiny humans.